Welcome to this short webinar on Medicare Therapy Utilization Guidelines. My name is Zachary Edgar, and my company is called Therapy Comply. Therapy Comply is a membership-based compliance firm dedicated to assisting physical, occupational, and speech therapy practices and facilities. Members can access a wide selection of guides, sample policies, and forms on Medicare, Medicaid, HIPAA, TRICARE, and state laws and regulations that apply to therapy practices. Members can also email me at any time with any compliance or billing questions or schedule a phone call. Please visit the website at therapycomply.com for more information. This presentation is for informational purposes only. None of the material is intended as legal advice. Statutes and regulations are all subject to change. These are general guidelines and not hard caps. Medicare uses these guidelines when reviewing claims and documentation. Rarely, except during an evaluation, should a therapy session be longer than 30 to 60 minutes. If longer sessions are required, documentation must support as medically necessary the duration of the session and the amount of interventions performed. The following codes should be reported no more than 1 unit per code per day per discipline. Additional units will be denied. These are generally a list of evaluations and assessments, so keep that in mind when billing. The following timed interventions should be reported no more than 2 units per code per day per discipline. Additional units will be denied. 97033, 34, 35, and 36. These are for the most part therapeutic activities, and they should not be reported for more than 4 units per code per day per discipline. Medicare expects an episode of care to be between 12 to 18 visits. This is not a hard cap. Documentation will have to show medical necessity for ongoing care. The progress note should be used to show that ongoing therapy is medically necessary through both objective measurements and the therapist's professional opinion. Documentation must clearly support the need for continued therapeutic exercise greater than 12 to 18 visits. Documentation recommendations for therapeutic exercises include objective measurements of loss of strength and range of motion with comparison to the uninvolved side and effect on function. If used for pain, include pain rating, location of pain, effect of pain on function, specific exercise performed, purpose of exercise as related to function, and instructions given and/or assistance needed to perform exercises to demonstrate that the skills of a therapist were required. Documentation must clearly support the need for continued neuromuscular re-education greater than 12 to 18 visits. Supportive documentation recommendations for neuromuscular ed include objective loss of ADLs, mobility, balance, coordination deficits, hypo and hypertenacity, posture, and effect on function. Specific exercises or activities performed, including progression of the activity, purpose of the exercise as related to function, and instruction given and/or assistance needed to support that the skills of a therapist were required. Documentation must clearly support the need for continued therapeutic activity treatment beyond 10 to 12 visits. Supportive documentation recommendations for therapeutic activities includes objective measurements of loss of ADLs, balance, strength, coordination, range of motion, mobility, and effect on function, and specific activities performed, and the amount and type of assistance to demonstrate that the skills and expertise of the therapist were required. Documentation must clearly support the need for continued manual therapy treatment beyond 12 to 18 visits. Supportive documentation recommendations for manual therapy include area being treated, soft tissue or joint mobilization technique used, and objective and subjective measurements of areas treated. May include ROM, capsular, Enfield, pain descriptions and ratings, and effect on function. Orthotic training can be completed in 3 visits. Supportive documentation for orthotic management and training include a description of the patient's condition, including applicable impairments and functional limitations that necessitates an orthotic, any complicating factors, the specific orthotic provided and the date issued, a description of the skilled training provided, and the response of the patient to the orthotic. If no objective and/or subjective improvement is noted after 6 treatments, a change in treatment plan, alternative strategies should be implemented, or documentation should support the need for continued use of the ultrasound. Supported documentation for ultrasound therapy includes the areas being treated, frequency and intensity of ultrasound, objective clinical findings such as measurements of range of motion and functional limitations to support the need for ultrasound, and subjective findings to include pain ratings, pain location, and effect on function. Documentation must clearly support the need for electrical stimulation for more than 12 visits. Some patients can be trained in the use of a home-tended unit for pain control. Only 1 to 2 visits should be necessary to complete the training. Supportive documentation for electrical stimulation includes type of electrical stimulation used, the area being treated, and if used for pain, include pain rating, location of pain, effect of pain on function. Only 1 unit of mechanical traction therapy is generally covered per date of service. Documentation should support the medical necessity of continued traction treatment in the clinic for greater than 12 visits. Supportive documentation should include the type of traction and part of the body to which it is applied, etiology of symptoms requiring treatment. If greater than 8 visits are needed for Whirlpool that require the skills of a therapist, the documentation should support the medical necessity of continued treatment. The supporting documentation should include the rationale requiring the skills of a therapist to apply, including the complicating factors and areas being treated. So for frequency, 4 to 7 times a week is considered high for outpatient therapy, but normal for home health and skilled nursing facilities. 1 to 3 times per week we consider normal for outpatient, but too low for home health and skilled nursing. And documentation must reflect the need for different levels of frequency. Medically unlikely edits. The purpose of the NCCI MUE program is to prevent improper payments when services are reported with incorrect units of service. CMS developed medically unlikely edits to reduce the paid claims error for Part B claims. And MUE is the maximum unit of service that a provider would report under most circumstances for a single beneficiary on a single date of service. So these are actually hard caps. So here are just a number of examples: therapeutic exercises, maximum of 6 per day; neuromuscular rehab, 4 a day; aquatic therapy, 6 a day; group therapy, 1; evaluations, 1 as well. Uh, these are for the beneficiary themselves. So even if you have different providers providing this therapy, you cannot go over these limits. So these are key to the beneficiary's number, not the NPI of the therapist or group. So I do want to highlight that there are 2 different kinds of MUEs. There's ones that are done by the practitioners and one done in the facilities. The practitioners being uh, PTs and OTs and SLPs in outpatient therapy, either on their own private practice or as employees to physicians. And there are MUEs in facilities such as skilled nursing facilities or hospital outpatient facilities, something like that. And these have actually higher caps pretty much for everything except for evaluations, though a lot of modalities are still 1 unit or 2 units. So just be aware that if you are in a different setting, depending on the setting, you're going to have different MUE caps. And on the right of those charts, you have the MUE adjudication indicators, either 1, 2, or 3. The 1, which you won't really see, indicates a value applied at the line level. The 2 indicates a value that was determined based on an absolute criteria, such as anatomic considerations and intrinsic definition of the code. That means that no matter what, you will not be able to appeal for more units beyond that if you have the 2 there. But if you have the 3, you may be able to appeal that if you can demonstrate medical necessity, though it is unlikely. Thank you for watching, and please visit the website for a lot more information and consider joining today.